So we are delighted that Professor Alexander joining us, and he's going to present the new EC guidelines for cardio-oncology. Alex, the floor is yours. Go ahead.
Thank you, Magdi, and thank you for the very kind invitation to speak at your meeting. I just wish I could be with you in person in Cairo. We do have the sun shining here in London this morning, but I suspect it's not as beautiful as with you. And thank you also to Professor Shawki for the kind invitation. This is my disclosures. I would like to start by acknowledging the work and collaboration with my co-chair for the guidelines, Teresa Lopez Fernandez from Madrid. So Teresa and I had the pleasure and privilege of chairing this first ever cardio-oncology guideline for the ESC. And we brought together a team of world experts to produce this, and it took 2.5 years. And if I have time at the end of the presentation, I'll just give you an insight into some of the numbers involved. And these were, as you can see, people from all over the world, not just from Europe. And importantly, we also had a patient, Richard Stevens. So we had a patient as a member of the writing task force. We also had over 100 reviewers internationally, and I see that Magdi's name is here on the list. So thank you, Magdi, for your time and effort, because we had great feedback from the reviewers and really valued what we heard and what they asked us to do to help tune the guideline. And I'll show you some numbers on that at the end. So this is the first ever guideline on cardio-oncology from the ESC, and we actually created this movie. It provides a guideline that provides information on definitions, diagnosis, treatment, and prevention of cancer therapy-related cardiovascular toxicities, this CTR-CVT. And you can see we cover all of these different cardiovascular conditions in cancer patients. Now, there's a core theme running through the guideline, and that's that the risk of a problem can change. It's a dynamic risk. So there are factors that influence the risk at baseline, and if you don't have any risk factors, you may be a low-risk patient to when you start in blue, but then you get exposed to the treatment, which increases your risk, and then you have your long-term risk. Higher risk patients at the beginning in purple have a higher risk during treatment and in the long term. And of course, those who develop a problem, develop the toxicity in the dotted lines, have the highest risk and for future lifelong heart problems. So we want to implement primary and secondary prevention strategies at baseline in the higher risk patients before, surveillance to pick up cardiotoxicity early so we can intervene early and prevent significant problems. We introduce an end of treatment assessment in the first year after completing treatment, and then guide who is at the highest risk and leads long-term surveillance in a cancer survivorship program. So this guideline has 272 new recommendations, and they, of course, follow the journey of the cancer patient from their time of diagnosis, during treatment, the first year, and long-term follow-up. And underpinning that, of course, is education of the patients and supporting and promoting a healthy lifestyle, both from a cardiovascular perspective and from a cancer perspective, with smoking cessation, exercise, and monitoring for diabetes, hypertension, and so forth. Now, there have been some recent new definitions of cardiovascular toxicities caused by cancer therapy, and these were published earlier in 2022 in the European Heart Journal. And I want to specifically highlight this one, which is about the heart failure, left ventricular impairment, and left ventricular dysfunction. So we call this cancer therapy-related cardiac dysfunction, CTR-CD. And you can see here that it can be divided in symptomatic, which by definition is heart failure, and asymptomatic, and then a severity scale from mild to severe. Now that's important, as you'll see that management algorithms depend on what the diagnosis is based on this definition. And here you can see that the clinical factors determining the symptomatic CTR-CD with clinical heart failure versus the asymptomatic cases where severe is if their LVEF has fallen to below 40%, Moderate is where the LVEF is 40 to 49%, and either has had a significant drop of over 10%, or where if it's less than 10% fall and into that low region, that there's been a decline in the global longitudinal strain of more than 15%, and or a rise of cardiac biomarkers. And mild cases is where the LVEF remains in a normal level above 50, but where they've had a fall in their GLS and or a rise in cardiac biomarkers. So the guideline starts then with risk stratification before cancer therapy. And of course, this is really for the oncologists and hematologists, so you need to share this with them. There are a number of factors which we recognize contribute to the baseline risk, including previous cardiovascular disease, age, genetics, if they've got a family history of cardiomyopathy, medical cardiovascular risk factors, lifestyle risk factors, and of course, obesity, smoking being very important. Baseline heart function. Do they have a normal or abnormal echocardiogram and cardiac biomarkers before they start? And for many cancer patients, it's a journey. They may have had a previous cancer or their current cancer's returned, and therefore exposure to previous cardiotoxic treatments. And we have the previous HFA and International Cardio-Oncology Society risk assessment pro formas for a range of cancer treatments, and you can download these from the position statement that we published in 2020. And essentially, you can then do a baseline risk assessment and classify a patient as low, moderate or medium, high or very high risk of cardiotoxicity from their treatment that they're about to receive. Here's an example then of how we would advise the baseline risk assessment based on their risk. And here's an example for anthracycline patients. So the high and very high risk patients should all have a baseline echo and cardiac biomarkers, natriuretic peptide and cardiac troponin. Those at low and moderate risk should all have an echo because you need that to complete the risk assessment, but it's a class 2A indication where the biomarkers should be considered, but in class 1 recommendation is for the high risk patients. We appreciate imaging is core to assessing heart function and structure in patients with cancer having cardiac treatments, or whether maybe the cancer is affecting heart directly. And we recommend echocardiography as the first line modality as a class 1 recommendation, with 3D echo, if you have it available, as the preferred modality to measure ejection fraction because of the reduced variability for patients having repeat measurement. And global longitudinal strain is recommended in all patients if they're going to have surveillance, because it's more sensitive to pick up early changes in heart function. And if the patient cannot have an echo because of very poor windows, maybe even without contrast because of previous left chest surgery, then cardiac MRI is the second line. If cardiac MRI is not available, then MUGA is the third line with a class 2B indication. So we now have this general approach to a patient who's got a diagnosis of cancer and they're going to be treated with a potentially cardiotoxic treatment. So there's the risk stratification with a 2A indication to use the HFA ICOS risk assessment. And then you have your low risk patients who can start their oncology treatment, have a review with cardiology if a problem develops, versus the moderate risk patients who we recommend closer surveillance and then referral if a toxicity develops. And for some selected moderate risk patients, maybe a cardiology referral up front is appropriate. Whereas for high and very high risk patients, it's a class 1 recommendation to be referred to cardiology. So these are the patients that you as cardiologists need to be ensuring your hematologists and oncology colleagues refer to you so you can optimize their cardiac status and define a more close monitoring. And then there's the use of cardioprotective strategies with a class 2A indication. So we'll come to that now as we look at how we prevent and monitor CV complications. So the context here on the left, you can see is some people have never had a heart problem and it's all primary prevention, whereas other patients have either got pre-existing cardiovascular disease or even have had cardiotoxic treatments, giving them previous cardiotoxicity, and now are on a new treatment regimen that has risk. So more in a secondary prevention strategy. Now, of course, one option is to minimize the use of cardiotoxic drugs if there are effective alternatives, but often it's the cardiotoxic drugs that are the most effective. And then we discuss which treatments, is there an option to have ACE inhibitors or angiotensin receptor blockers, with or without beta blockers for primary prevention in patients with anthracycline chemotherapy who are at high risk, dexrazoxane or liposomal anthracyclines. This is a 2A indication if they're high or very high risk patients, but do need to have the anthracycline. And there's been debate about the role of statins, and certainly if you have a vascular risk, then starting statin therapy, if not already on it, is indicated. Now, I won't go through all of these, but you can see that we cover a wide range of modern cancer therapies that we know can cause cardiovascular toxicities. So in the guideline, under the baseline assessment and surveillance, there is a section for each of these different treatments. And I just wanted to show you an example for anthracycline chemotherapy. So this could be for a breast cancer or a lymphoma patient where they're guided into low, moderate, and high risk. On the left, you can see ECG, echo, and biomarkers, cardiac troponin and natriuretic peptide, and who should have these at baseline, and then at what timing during treatment. So you can see a low-risk patient who should have an echo may have nothing until a 12-month review. That's the only assessment that is definitely recommended. But there is an option that could be considered for an assessment after the 4th cycle, and likewise biomarkers. But those are class 2B, may be considered. At the other end of the spectrum, the high-risk patient should have a biomarker measurement with every cycle, and transthoracic echo, which can become focused every 2 cycles, and then an early review at 3 months. And all patients in all risk groups should have their end of treatment assessment at 12 months. We also recognize that radiotherapy to a volume, including the heart in the radiation treatment field, can cause long-term cardiac problems, particularly vascular problems, and hence the role of a vascular risk assessment to ensure that if they're in a higher risk group, should they be starting statin therapy, have their diabetes optimized, have their hypertension optimized. And of course, their risk also depends on the dose of radiation they're going to receive. And if they've also been treated with doxorubicin, then there's an interaction there. The next section of the guideline looks at the management of cancer therapy related cardiovascular toxicities. And it's important to highlight that this guideline is looking at where the management is different to if you were treating the same cardiac condition in the general population, because of course we've got guidelines for all of those issues. This is about whether cancer patient related heart toxicity leads to a different treatment plan. And of course, this will be balancing the symptoms of the patient from their cancer and from their cardiovascular condition. The prognosis of the cancer, is it early invasive or is it metastatic, but is it a low risk metastatic with long-term good prognosis if they're on chronic treatment? We also want to know what the alternative cancer treatments are, including safer, less cardiotoxic treatments. There's important thought process about the cancer drug, cardiac drug interactions. In the status supplement, we have an extensive list of the drug-drug interactions. And finally, of course, there's the patient voice and their preference when they're weighing up the risks of continuing versus stopping a cancer therapy and or starting cardiac drugs. So in this section, we cover these range of heart conditions and cardiovascular diseases that are caused by the cancer treatment and provide management algorithms. So I'm going to share with you a few examples. This is the management algorithm if it's an anthracycline chemotherapy related cardiac dysfunction. In the top third, you can see that we first of all start with the diagnosis, and that's based on the definitions which I showed you earlier. Is the patient symptomatic or asymptomatic, and how severe is the problem? In the middle third is what the oncology treatment plan is. So at one level, if you've got severe symptomatic heart failure and you'd be admitted, you discontinue the anthracycline and it's highly unlikely you'd restart. At the other end, If you're asymptomatic and mild, based on a drop in GLS or a rise in a biomarker, but where ejection fraction is stable and the patient's asymptomatic, it would be to continue treatment, but with closer cardiovascular monitoring for the oncology treatment strategy. And you can see that interruption and an MDT discussion for moderate dysfunction is appropriate. And then for the more severe cases, heart failure therapy is recommended. So in the lowest third is the cardiovascular treatment strategy. And in these milder asymptomatic cases picked up on surveillance, we discuss where ACE inhibitors and or beta blockers should be considered or may be considered depending on the abnormality that's been detected in anthracycline-related cardiac dysfunction. We have a similar algorithm for trastuzumab and the other HER2-targeted therapies that are used often in HER2-positive breast cancer, and there's a whole range of these treatments now. So again, the algorithm shows in the top third, based on the definite diagnosis, what then the management strategy is for the cancer treatment, the trastuzumab in the middle third, and the cardiovascular treatment in the lower third. And I just want to highlight one new change in practice. So in a woman on surveillance receiving trastuzumab who develops a moderate asymptomatic CTRCD, so that's where her LVEF has fallen into that 40 to 49% range, but she's asymptomatic, then we recommend starting heart failure therapy, but also continuing the trastuzumab uninterrupted, but with closer CV surveillance. And that's a class 2A indication. So continuing treatment, not stopping it based on an asymptomatic decline into the moderate range, should be considered. Here's the algorithm for management of immune checkpoint inhibitor-related myocarditis, which is becoming an increasingly recognized problem with these drugs, which are now widely used in a range of cancers. So once you've had a diagnosis of this condition, the patient should be admitted to hospital, have continuous ECG monitoring, and the checkpoint inhibitor treatment stopped. That's a class 1 indication. They should be treated with a daily dose of high-dose methylprednisolone for the first 3 days, again, a class 1 indication. And then based on their response, they either recover and can switch to oral prednisolone and have weaning on a weekly basis with troponin monitoring, and that's a 2A indication. If they're not responding to the steroids, then second-line immunosuppression. And of course, if they're extremely unwell, hemodynamically unstable, VT, cardiogenic shock, then they need ITU admission, optimal cardiovascular treatment. And because many of these patients may have a good prognosis, in a conversation with the oncologist, you can consider mechanical support if they've got cardiogenic shock, and this is a very reversible condition. QTc prolongation is common in cancer patients. It's common because of lots of the other drugs they're on, like antiemetics, antibiotics, and because of diarrhea, vomiting leading to electrolyte disturbances. But we also know that many cancer drugs themselves can cause QT prolongation. A large number cause a moderate risk, but these are the group here that have the highest risk. So what we have introduced in the guideline is this algorithm for how to manage this topic in cancer patients. And of course, it starts with what their baseline corrected QT interval is. And if it's already prolonged before they're scheduled to start a drug, then you need to understand whether that can be reversed or alternatives need to be considered. If it's relatively normal and you start treatment with a drug known to cause QT prolongation, then there's ECG monitoring for the first few weeks. And then depending on the change in the QT interval, we provide guidance on what to do. And if it is prolonged and then the cancer drug stopped, what happens based on the response, which we hope will be helpful for you because these are often difficult topics and concepts. I won't run through all of these, but to show you that we have examples for the new cutoffs and treatment algorithms for arterial hypertension caused by cancer drugs, Takotsubo syndrome, where we feel the cancer drug is responsible, and also decisions on anticoagulation, where patients develop atrial fibrillation or venous thromboembolism, and the selection of which anticoagulants to use. The next section of the guideline looks at the end of cancer therapy cardiovascular assessment, which we recommend in the first 12 months after completing treatment. And again, the concept is to identify the high-risk patients based on their baseline risk, even before they started, if it was high or very high, those who've received relatively high doses of cardiotoxic treatments, or high-risk bone marrow stem cell transplant patients, the patients who've developed at least a moderate or severe cancer therapy-related toxicity, such as heart failure or CTRCD and myocarditis, but all the different toxicities. And of course, if they were a symptomatic patient at the end of their treatment with new cardiac symptoms. We also consider the patients who started heart treatment because surveillance picked up a problem during their cancer treatment, and then they were allowed to continue as their heart hopefully recovered, as to who needs to continue on long-term heart failure treatment after completing their cancer therapy and who can have it weaned. So, of course, those who had severe or very severe toxicity, we recommend they continue long-term heart failure therapy. But for those cases who are mild to moderate and they fully recovered and now asymptomatic, so if they've not recovered, they continue treatment, but if they have recovered, then we recommend an MDT discussion, a review of these risk factors to work out their risk of future LV impairment if their treatment is weaned. And if they're high risk, then they should continue treatment. But if they're low risk, then we recommend a trial of weaning, and that should be considered with a 2A indication. And actually, a lot of patients are in this low risk category and can be weaned off safely. The next section of the guideline looks at long-term follow-up in cardiovascular complications in survivors. And again, we look at risk. There's two tables here to help guide you on understanding the risk of the cancer survivor. The first is for those asymptomatic adults who were survivors of a childhood or adolescent cancer, where at the time of treatment, their risk is because of their young age with a growing, developing heart, and dependent on the dose of radiation to the heart as mean heart dose in grays, or their total anthracycline dose that they received. And if they got both treatments, then the thresholds are lower on these doses because we know there's a synergistic effect of the toxicity. And for an asymptomatic adult cancer survivor, again, we have these risk factor groups and that allow you to understand whether the survivor is in a low, a moderate, or a high risk for future heart failure or other cardiovascular diseases. And based on that, we've provided guidance on who needs long-term surveillance. So low-risk patients do not need any extra surveillance. Moderate-risk patients, if they're an adult who survived a childhood cancer, we recommend that an echocardiogram should be considered every 5 years and may be considered if they're a survivor of an adult cancer. Whereas the high and very high-risk patients, we recommend an echocardiogram every 2 years because they're at high, short, or long-term risk of heart failure. And if they're fine for the first 5 years after an adult cancer, then you could reduce to every 5 years if everything is normal in the first 5 years. We'll also discuss the management of a range of different complications in cancer survivors, including how to manage the cancer survivor who is female who becomes pregnant. Finally, we have areas of special populations. So we have a section on cardiac masses and tumors and how to investigate and manage the tumor, a section on the cardiac complications of carcinoid syndrome and carcinoid valvular heart disease, AL, cardiac amyloidosis in the context of multiple myeloma or a plasma cell dyscrasia. And as I mentioned, if you have also a woman who is pregnant, who then is diagnosed with cancer whilst she's pregnant and needs anthracycline chemotherapy because it's a breast cancer or a lymphoma where those are critical, how to manage the pregnant woman with cancer receiving a cardiotoxic treatment. And finally, we have a section on management of our cardiac patients who have a cardiac implantable electronic device such as a pacemaker or defibrillator who need radiotherapy. And we can classify their risk about whether the device is within the radiation field that's planned, what the dose of radiation that's planned, and from a device perspective, is the patient pacing dependent or independent? And if it's the defibrillator, have they had regular or frequent appropriate therapies that put them in a high risk category. And then we have algorithms of how you can manage these patients during their radiotherapy, depending, and one algorithm is if the device is within the radiation field, and the other algorithm is if the device is remote, so radiotherapy to the lower half of the body. So to summarize, we have 272 new recommendations. On the left, you see the classes with over 50% being class 1. And if you put together the class 1 and class 2A, it's over 3/4 have got guidance, which we hope will help. On the other side is the level of evidence, and we still need more research in the field, and 3/4 of the recommendations are a level of evidence C, so not supported by randomized controlled trials. We have a range of educational tools, and I particularly highlight the Pocket Guideline app because it has many of these algorithms and the baseline risk assessment as interactive. So you can also show this to your hematologists and oncology colleagues because they will be performing the baseline risk. And shortly, we'll have a patient version and summary that will come out, and I hope will be translated into all the languages of countries affiliated to the ESC. So finally, I just wanted to share with you a bit of experience of the numbers involved in this guideline. So I've mentioned 272 new recommendations. There were 837 references, 48 figures, including 26 algorithms, 15 tables, and one video animation we showed you, which we think is certainly the first ESC guideline with a video. We had 30 co-authors from 13 countries, including one patient, 103 reviewers from 57 countries, including Egypt, and 2 patient reviewers. And in total, the reviewers provided 2,512 reviewers' comments across 3 rounds. So next time you submit a paper to a journal and get the reviewers' comments back, just reflect on Teresa and I receiving 2,500. The whole guideline took 859 days from the start to the finish. That was during one COVID-19 pandemic, and therefore we had no face-to-face meetings to create the guideline, and therefore relied on Zoom, including some of the longest Zoom meetings I think any of us had sat through, with 3 8-hour Zoom task force meetings. And finally, from the ESC Clinical Practice Guideline Committee team, Teresa and I received 604 emails. We had an additional 911 emails between us, and obviously in the modern world, we could communicate with WhatsApp and had 1,901 WhatsApp messages and calls just on the guideline. So with that, I'd like to open it up for discussion. As you know, it's been published in the European Heart Journal late in August, simultaneously with its presentation at the ESC Congress. When I looked earlier this week, the web page had over 116,000 views, and there had been over 38,800 downloads. So you can see the impact, I think, for cardiology, but also for oncology and hematology. And I hope this will help you in the management of these patients, which often are very complex with the balance of risk and benefit. So thank you for your attention, and I look forward to the discussion.
Thank you so much, Professor Leon, for this wonderful presentation. Before going to the discussion, I'd like to welcome my co-chair, Professor Nadi Michel. He is the past chairman of the cardiology department at Police Medical Services. Professor Azza Al-Fiqi, professor and the chairman of the cardiology department at Ain Shams University. Professor Reham Darwish from Cairo University. First of all, congratulations for this amazing document, which is well written, great job, and you are the leader with Teresa for this fantastic new cardio-oncology guidelines. A lot of new recommendations, statements, which needs many hours for extensive discussion. So for the sake of time, I have 2 questions, then I will leave my co-chairman and the floor for more questions. My first question regarding the role of genetic predisposition to cardiotoxicity. So how can we know that some patients are prone to develop cardiotoxicity while others are at low risk from the genetic standpoint. The next question, which is important because we have many colleagues here from big tertiary referral centers, so you'd like to know how to establish a cardio-oncology program, specific protocols for seeing patients and follow-up patients who are receiving anti-cancer therapy. So how can we do that? Thank you very much.
Thank you, Magdi. Two great questions. So in the answer to genetics, we have not included any recommendation on performing cardiomyopathy genetic testing or any pharmacokinetic genetic testing to try and identify higher risk patients, because there's not evidence yet that that's effective. We do know that the rates of cardiomyopathy gene mutations are enriched in patients who present with chemotherapy-related heart failure. And in fact, I was one of the co-authors of a paper that showed that the rates of Titin mutations and other myofilament mutations were at 12% in patients with anthracycline-induced cardiotoxicity and LV impairment, compared to a background rate of 2 to 2.5% in the general population. So at the moment, screening everybody for a 2% rate does not look cost effective. You could consider in your patients who've developed problems, and particularly if they've been very sensitive, a relatively low dose of anthracycline leading to a very severe heart failure phenotype. I think there could be the role for genetic testing, but we have not recommended it routinely. I think if you've got a patient who's got a family history of dilated cardiomyopathy or hypertrophic cardiomyopathy who then develops problems during their cancer treatment, you would consider they're likely to be at higher risk. And again, genetics may be indicated in that group. Moving to your second question, which is the most important in many ways, to how do we implement and create cardio-oncology centers? So I've got a few take-home messages and pieces of advice. The first is that in 2018, we published from the ESC Cardio-Oncology Council a position paper on cardio-oncology services and what the structures look like and what you need to do. So I'd recommend your colleagues read that paper. I think if there's one key factor, it's building up the professional relationship with your oncology and hematology colleagues. You have to build a relationship where you can communicate, you can understand what they're saying and what they're trying to do with their treatments. They need to also be aware of what we can do to help. And a lot of this is keeping patients on cardiotoxic cancer therapies safely so that they can get better cancer outcomes. And as soon as you present it in that context to the oncologist, then of course they want better outcomes for their cancer patients and a better cancer-free survival or longer-term life if the cancer is a chronic disease. So it's about communication. And then finally, in a cardiology center, there's a huge demand on echo and then on other imaging resources. So building up a pathway, because if someone's waiting for their cancer treatment and needs an echo, it's got to be done urgently. You can't say, do it, come back in 3 months. It's got to have a rapid access to urgent care. I hope that's helpful.
Yeah, great. Okay.
Is anybody on the floor wants to ask a question? No, it seems not. I'm going to ask a question, please. I'm asking if a patient is on anthracycline, for instance, and he developed from mild to moderate heart failure, and we are giving him anti-failure measures as the usual, but we cannot shift to another medication. What shall I do? When am I going to repeat the cycles again?
Yes, so I'm going to use the definition structure because I think that's how you need to approach it. So you talk about mild to moderate heart failure. Well, it makes a big difference. Is it mild or is it moderate? And whether the patient's symptomatic or not. And then what if it's whilst they're on anthracycline chemotherapy, and if it's moderate and the LV function has dropped below 50%, but into that 40 to 49% range, which is moderate CTRCD, their anthracycline chemotherapy should be paused You start effective heart failure treatment depending on their physiology. Beta blockers, our preferred one is carvedilol, and then ACE inhibitors or angiotensin receptor blockers. We rapidly up titrate, so we often do weekly dose increases, so much more rapidly than a regular heart failure patient, and then reassess. And if the reassessment shows the ventricular function has fully recovered and the biomarkers have improved, then there's a risk benefit discussion with the oncologist and then with the patient about restarting the anthracycline chemotherapy. So it's not that everyone can restart or everyone should stop. It's got to be personalized based on their response. But if you follow the guideline algorithm, it gives you the opportunity to then identify who can restart. And of course, if you do restart, let's say they've only had 2 cycles and they've got 4 to go, you want to have much more closer monitoring because they're a high-risk patient.
Yeah, thank you very much.
Professor Leon, last question. Do we have enough data about the role of SGLT2 inhibitors as a prevention of cardiotoxicity?
Great question, Magdi. Short answer, no. There haven't been any major trials. There have been some interesting abstracts presented at different congresses where there's been early experience. Of course, if we start from the position of first principles of science, one has to think, well, how do SGLT2 inhibitors work in heart failure? And we don't actually know the answer to that. So when we're then thinking, how may they work in cardioprotection or in rescuing, we got to also understand the mechanisms. And it may be very different, for example, for anthracyclines versus the mechanisms for trastuzumab, versus a lot of the tyrosine kinase inhibitor molecules now developed where we also see LV impairment with VEGF TKIs and a new EGFR inhibitor called osimertinib for EGFR mutant lung cancer. So different mechanisms may require logically different protection strategies, but I personally believe there will be a role for SGLT2 inhibitors in this field.
Thanks. So on behalf of the board members of the Egyptian Society of Cardiology, I'd like to thank you so much for your excellent contribution. We enjoyed your presentation. We enjoyed the fruitful discussion. And we are looking to seeing you soon in Cairo in person next time. Thank you so much.
I look forward to visiting Cairo. Well, thank you again, and enjoy the rest of your meeting.
Thank you. Bye.
It's my pleasure to begin this session about the guidelines of ventricular arrhythmias and sudden cardiac death updates. Professor Dr. Ahmed Damati will begin the session, will give us a talk about this. He's the eminent electrophysiologist, scientist, and teacher of electrophysiology at Nasser Al Aini Hospital.
Okay. طبعا احنا بنهني الدكتور الاخ العزيز الاستاذ دكتور مجدي عبد الحميد، دايما ناجح ودايما مشرف الجمعيه المصريه لامراض القلب، ويعني انجازات علميه واحده تلو الاخرى بالتوفيق ان شاء الله. طبعا دكتور احمد الضماطي ابني بصراحه العزيز جدا، ويعني خير من يمثل القصر العيني، يعني مشرفه طبعا مع اساتذتي الدكتور عصام، دكتور احمد رزه، دكتوره عزه، فانا سعيده ان احنا في وسطهم، وان شاء الله يبقى يوم علمي جميل باذن الله.
مساء الخير جميعا اساتذتي وزملائي، بيسعدني ان ابقى مع حضراتكم النهارده، وبشكر دكتور مجدي على الدعوه الكريمه. ان شاء الله هكلم حضراتكم النهارده على الجايد لاينز اليوروبيان that discusses sudden cardiac death and ventricular arrhythmias published this year. So this is the objective, is to go through the guidelines, and we are going to do this through discussing the medical status of 4 people, 3 gentlemen and a lady, that goes through the spectrum of cardiovascular diseases. So first of all, VT in coronary artery disease. This gentleman, Mr. HS, is 50-year-old gentleman who presented with anterior wall myocardial infarction. He had PCI to his LAD and was discharged on guidelines-directed medical treatment. On discharge, his ejection fraction was 35%. He came back in the first follow-up visit after 6 weeks with his ejection fraction improving up to 45%, but he had frequent PVCs and non-sustained ventricular tachycardia. And the question is, what is the best practice in view of the current guidelines in terms of preventing the sudden cardiac death in this gentleman? And to be able to answer this question, we have to know that people with chronic coronary artery disease who have an ejection fraction that is less than 35% have a well-established indication, according to the MEDIT-2 study, to have an ICD. But our patient is different. After 6 weeks of his myocardial event, he had an assessment of the ejection fraction that turned out to be somewhere in the 40s. But unfortunately, he had non-sustained ventricular tachycardia. فالسؤال, does this put him at a higher risk than an average patient who gets a myocardial infarction with a stable rhythm ولا لا؟ والإجابة yes. And based on this patient has to have a programmed electrical stimulation, so an EP study. If he gets sustained monomorphic ventricular tachycardia, that's a class 2A indication for an ICD, and if he does not, he can be followed along and preferably gets an implantable loop recorder to follow his rhythm. And this is based on the MUST trial, a time-honored trial. So this is what happened. Mr. HS had a negative EP study and was risk stratified as having a low risk of sudden death and was thus followed up along conservatively. On optimizing his medical treatment, his PVCs and non-sustained VT settled. But few years later, he came back with sustained monomorphic ventricular tachycardia. So what does the guidelines tell us now? If this patient has a structural heart disease and he came in with sustained monomorphic ventricular tachycardia, if it's hemodynamically unstable, that's easy, DC shock. But what is different in the current guidelines is that if this patient has sustained monomorphic VT and his anesthesia risk is low for cardioversion, the class 1 indication is to cardiovert him rather than give him medical treatment. And medical treatment, which is procainamide and amiodarone, the class 2A and 2B, are not really class 1. So whenever you get the patient, we are sure that he has a structural heart disease, sustained monomorphic VT, even if he is hemodynamically unstable, if the anesthesia risk is low, you're justified to cardiovert him. So this is what happened. His VT settled on medical treatment and his ejection fraction remained stable despite the occurrence of VT, and he's about to be discharged from the hospital. And the question now, what would you do next based on the current guidelines? So according to the 2015 guidelines and according to the current guidelines, this patient still qualifies for an ICD because he has sustained monomorphic ventricular tachycardia. But here are some details. If your patient ejection fraction is low, like less than 35%, that's a clear indication for an ICD. While if your patient ejection fraction is more than 40% and he gets a hemodynamically tolerated VT like our patient, you have an alternative. So ICD remains an option, a class 2A indication, but catheter ablation is now an option. It didn't used to be so. So with patients who have a preserved ejection fraction, sustained monomorphic VT, you can do catheter ablation instead of putting an ICD. But you have to have some prerequisites. You have to have this ablation procedure in an experienced center, and you have to have non-inducibility as an endpoint after the procedure. So if you satisfy this criteria, you can just do an ablation procedure and follow your patient along, provided that he has a preserved ejection fraction. So Mr. HS decided to go for the ICD, the classic protocol, and he was discharged on amiodarone that was later had to be changed for sotalol because of amiodarone-induced thyrotoxicosis. He came back with recurrent appropriate ICD shocks And the question is, what would you do now in his management? So if a patient comes in with recurrent appropriate ICD shocks and he is on amiodarone, the correct answer would be doing a catheter ablation procedure. We have a solid data from the VANISH study that randomized patients on amiodarone therapy to escalation of medical treatment, like increasing the dose of amio or adding a mexiletine over the amio versus catheter ablation. And there was a clear benefit in terms of the composite endpoint of hospitalization as well as mortality in terms of improvement in the catheter ablation arm. So we have a clear benefit from the catheter ablation versus escalating medical treatment. But if your patient is amiodarone naive, so he has not been on amio, you have the options of catheter ablation or putting sotalol or putting amiodarone, all knowing that sotalol is quite a weak medication and you might end up facing the same scenario again if you discharge your patient on this drug. Mr. HS opted not to go for an ablation procedure at this point, and he preferred to continue on medical treatment. Unfortunately, in few weeks, he bounced back to the hospital in VT storm. And the question is, what would you do next? So the answer is pretty clear. You have a sustained monomorphic VT that is recurrent. What can you do? First of all, you need to optimize your ICD programming. You add beta blockers, sedate your patient, perhaps start reloading of intravenous amio. And if this does not work, you go for catheter ablation as a class 1 indication. You can use other maneuvers such as going for a deep sedation or anesthesia, so intubate your patient and complete general anesthesia. You can do autonomic manipulation through cutting the left cardiac sympathetic chain, or you can use mechanical circulatory support, or you can do overdrive pacing. So eventually, Mr. HS had his VT ablation procedure, and since then, he has been doing well. This lady is a patient who came in with VT, and she has apparently structurally normal heart. So she is Miss DM. Miss DM is previously healthy. She's 33-year-old with no cardiac history, and she presented with the following ECG, and the question is, what would you do next in her management? So this ECG is frequently seen in patients with normal heart. So a left bundle looking ventricular tachycardia with an inferiorly directed axis speaks of a right ventricular outflow tract tachycardia, quite pathognomonic. So what can be done in terms of long-term management of this particular patient? If the patient has structurally normal heart and she came in with either VT or frequent PVCs, you have to think about symptoms. If the patient is symptomatic, and probably if she has sustained VT, she is symptomatic, you need to do something, whether this something is an ablation procedure or a medication, but you never put in an ICD. So if the VT is coming from the right ventricular outflow tract or the left fascicle, the class 1 indication in this case is catheter ablation. And class 2A is the use of beta blocker, calcium channel blocker, or flecainide. It's completely the other way around if the ventricular tachycardia or the PVCs are coming from elsewhere. This, of course, emphasizes the fact that right ventricular outflow tract or fascicular ventricular tachycardia can be easily ablated with a high success rate and quite low complication rate. So this would emphasize how you proceed with your patients. So after discussing the pros and cons of each treatment modality, Ms. DM opted to go for medical treatment. She was maintained on calcium channel blocker. But in general terms, what would you prefer in terms of medical treatment for such patient who came in with PVCs or idiopathic VT? So these are the modalities of therapy, medications and ablation, and these are the kinds of VT. So obviously the green squares or rectangles are class 1 indications, the yellow one are class 2 indications, and the red ones are class 3 indication. So the general rule, if your VT or PVCs is coming from the fascicle or the right ventricular outflow tract, ablation is a class 1 indication. If it's coming from elsewhere, medications, namely beta blockers and calcium channel blockers, are the class 1 indication. If you start to have LV dysfunction, amiodarone that is class 3 indication in normal hearts starts to be an option. And if you have PVCs that count is very high and the patient is asymptomatic with normal ventricle, amiodarone is contraindicated. Of course, this emphasizes the fact that amiodarone has to be reserved only when it's the sole indication, when it's the sole option. And ablation becomes a class 2B indication when the patient is asymptomatic. So the clear indications for treating PVCs is that when your patient has an impaired ventricle or symptoms. But when the count is so high, it's a class 2B indication. So she did well for some time, but she never had VT. She continued, though, to complain of palpitations every now and then. That was well tolerated. Till 2 years later, when she started to feel short of breath, her ejection fraction recently dropped to 45%, and her Holter showed a PVC count of 15%. And the question is, what's the next step in management? So this guidelines emphasized the entity of PVC-induced cardiomyopathy or PVC-aggravated cardiomyopathy. And it is an entity where you need to think about when there is no etiology of the cardiomyopathy and the PVC count is more than 10%. So what's the key investigation that you do in these situations? You do a CMR. CMR will answer the chicken or the egg question. Is it the DCM that caused the PVCs, or is it the PVCs that caused the cardiomyopathy? And of course, if you have late gadolinium enhancement, it's going with a DCM with secondary PVCs that can be treated with catheter ablation or amiodarone. And if you have no late gadolinium enhancement, you know that this is PVC cardiomyopathy, and catheter ablation gets to be a class 1 indication, because at that point, if you get rid of the PVCs, that's a curable form of cardiomyopathy. Ms. DM had her PVCs ablated, and since then, she has been doing well. Our third patient is a patient who developed VT in the setting of a primary electric disorder. Mr. BS is a 17-year-old gentleman who presented following being resuscitated from a VF arrest. He was cooled, ventilated, and he is gradually recovering without a clear neurologic deficit. And the question is, how do you investigate him? What is the next step in his management? We need to prevent this event that was life-threatening. And the guidelines offer quite a long algorithm for how to deal with the survivor of sudden cardiac death. It starts off with excluding myocardial infarction, and if it's present, deal with it accordingly. But then it tries to search for a non-cardiac etiology by doing brain and CT chest and toxicology analysis. If there is no extracardiac etiology, it goes back to the possibility of primary electric disorder of the heart, which can range from pre-excited atrial fibrillation, which is evident in a surface electrocardiogram, till a very complicated electrical disorders like CPVT or Brugada syndrome that needs extensive testing up to genetic testing. So what happens next? You look for the rarities. So you do a CT angiography to rule out coronary anomalies. You do CMR to rule out late gadolinium enhancement. And then you look for the primary electric disorders through either a sodium channel blocking test or an exercise test to exclude long QT that was latent, or perhaps you do an ergonovine test to rule out coronary spasm. So a long list of investigations that you have to go through to figure out what's the etiology behind the cardiac arrest that happened to your patient. Mr. BS was extubated. All his investigations turned out to be negative. He was planned for an ICD prior to hospital discharge with the notion that he had an idiopathic ventricular fibrillation. But while on the ward, he developed a VT storm that required recurrent defibrillation, sedation, and intubation. On review of his telemetry, the following tracings were recorded. And what is striking here is this monomorphic-looking, short-coupled PVC that happens in Bigemini in his telemetry. And what's more striking is that you can see one of these PVCs of the exact same morphologies as the previous ones, starting ventricular fibrillation. So this is a variety of torsade that we call short-coupled torsade that the patient gets out of short-coupled PVCs that starts ventricular fibrillation. And the question is, what's the next best step in this management? The patient will get the ICD because there is no other therapy modality that will prevent this from absolutely happening, but he can get a catheter ablation procedure as well to get rid of this monomorphic PVC. And that's what happened. So this is how you treat a VT storm in the setting of polymorphic ventricular arrhythmia. It depends on the etiology. If you have acute ischemia, you go to the flow chart. If you have external precipitating factor, you treat it. If you have polymorphic VT triggered by a monomorphic PVC, you do catheter ablation. Kinidine remains an option. If you have acquired long QT, you treat the founding drug or etiology, be it hypomagnesemia or hypocalcemia. If you have a primary electric disorder of the heart, it depends on the etiology. If you have Brugada syndrome or idiopathic VF, the treatment of choice in terms of medication would be isoproterenol or kinidine. Catheter ablation can be done in some cases of Brugada syndrome. But if you have long QT, of course, the treatment option is beta blocker. And if it's long QT3, you might resort for mexiletine, and sympathectomy remains an option. So meanwhile, when you figure out the etiology and treat the cause, if you have recurrent ventricular arrhythmia, the only answer is deep sedation and circulatory support. That is the thing that can save your patient life. Mr. BS had his PVCs ablated, and since then, he has been doing well. And finally, we will go to the long QT syndrome. Just quick update on what's important, only what's important. Genetic counseling is essential. Beta blockers, now namely nadolol and propranolol, are the treatment of choice for long QT 1 and 2. For long QT 3, you go for mexiletine. It's now a class 1 indication. For Brugada syndrome, ablation has had the upper hand in terms of the updates. So catheter ablation is contraindicated if the patient is asymptomatic. But if the patient is symptomatic and he gets triggering PVCs, or he has an RVT epicardial substrate, this patient is now a class 2 in 1A indication. For catheter ablation, he used to be a class 2B indication. For CPVT, what's important is emphasizing the role of left cardiac sympathetic denervation in patients who has CPVT, who are on a combination of beta blockers and flecainide, but they still get ventricular tachycardia. Finally, cardiomyopathy, patients with cardiomyopathy. So this gentleman, Mr. PG, is a 45-year-old gentleman who is previously healthy. He presented to the outpatient clinic following an episode of sudden unheralded syncope. His physical examination was normal, and his electrocardiogram showed first-degree heart block, right bundle branch block, and his echocardiography showed an ejection fraction of 45%. And the question is, what would you do next? So what we do next is based on this algorithm endorsed by the recent guidelines, and it emphasized two important things. So first of all, the seminal role of CMR as a class 2A indication in patients with dilated cardiomyopathy or patients with hypocontractile non-dilated cardiomyopathy. Because if you have scar in the CMR, and if you have two or more risk factors, like a family history of sudden death, or AV block at young age, or non-sustained ventricular tachycardia, that's a straightforward indication for an ICD. But if you have these with a preserved ejection fraction, but unexplained syncope, you now need to do programmed electrical stimulation, and that's an upgrade for the role of programmed electrical stimulation in dilated cardiomyopathy. It used to be a class 2B indication because of the doubtful value, but that's an upgrade. If you get sustained monomorphic ventricular tachycardia in this patient, that's an indication for an ICD. If you don't, you can put an implantable loop recorder and follow your patient along with the notion that his syncopal episode could have been a benign vagal syncope. And finally, ICD implantation should be considered in patients with DCM who are symptomatic, class 2, 3, or 4 NYHA, with an ejection fraction that is less than 35% after 3 months of optimized medical treatment. So what's the difference? The difference is that in 2015, this was a class 1 indication. In 2022, this is a downgrade, class 2A indication. And of course, this is because of the Danish study that questioned the role of primary prevention ICD in patients with dilated cardiomyopathy. So this patient had an MRI, turned out that he has a scar, and he had his ICD implanted, and since then he has been doing well. My take-home message would be the central figure that the ECC picked to be their central figure in this publication, which is a very interesting figure. It classifies the several diseases that puts your patient at the risk of sudden cardiac death. It gives you an idea about their genetic risk of developing ventricular arrhythmia. It gives you an idea about the trigger. So for an example, exercise triggers CPVT. Exercise, particularly swimming, loud voices, or sleeping can trigger long QT in their various subtypes. And Brugada syndrome can be triggered during sleep. Also, it gives you the age that your patient is at higher risk of developing ventricular arrhythmia. So for example, you have in ARVC a peak at young age below 20, and then a decrease in the incidence in the 20s, and then another peak between the 30s and the 40s. And finally, it gives you the presentation whether your patient will present with polymorphic VT or monomorphic VT. So obviously, if that's a CPVT or LQT or Brugada, one of the channelopathies, the first presentation is more likely to be polymorphic ventricular tachycardia. While if you have a structural disease, such as Fallot or ARVC or DCM or coronary artery disease, you will have higher incidence of monomorphic ventricular tachycardia and lower incidence of polymorphic VT. And with that, I conclude. Thank you very much. Any questions?
Very elegant as usual.
دكتور احمد، في الكلينيكال براكتس بقى، هل حضرتك تتصور احنا مثلا زمان كان الاس في تي والفينودال تاكيكارديا وكده، كنا زمان بنبعت العيان يعمل ابليشن واحنا عارفين السكسس ريت بتاعنا 75 70% كده. دلوقتي السكسس ريت بقى 95 واكتر يعني. هل حضرتك متصور ان احنا in the progression بتاع التطور اللي احنا فيه، ان احنا بعد كده هيبقى متوقع ان الابليشن هو هيبقى ليه الابر هاند زي ما هو دلوقتي بقى في الاس في تي؟
I really think that, thank you for the very important question, Dr. Assam. I really think that we are heading in this direction. يعني we are more and more towards risk stratifying patient to fine tune whether the patient needs an ICD or not. Unfortunately, up till now, the guidelines are based on the ejection fraction only, which is a very crude indication. Like you have patients with ejection fraction of 30 and they live without any shocks from the device. And you get patients with an ejection fraction of 45 who will end up dying suddenly because you deny them an ICD. So we have several markers, none of them took off yet, but we are heading in this direction. With this hand in hand, with the improvement in the ablation techniques, more patients with preserved ejection fraction will be sent to this limb of therapy, namely catheter ablation, and the lower patients perhaps will be sent to the ICD group.
طب هو السؤال التاني، احنا ليه دايما كلنا متعودين ان احنا العيان اللي عنده frequent BVCs ليه ما بنبدأش بالسوتولول قبل الكوردرون؟
لا هو احنا لازم هو احنا يعني الاميودارون لازم يكون اخر محطة.
يعني نبدأ بالسوتولول قبل الاميودارون؟
ده ضروري. The beta blockers, calcium channel blockers, sotalol, flecainide, provided that the patient has a normal ejection fraction. الحاجة الوحيدة اللي بتزنقنا في خانة الاميودارون هو impaired ejection fraction. وده بقى على حسب المريض. يعني لو هو basically PVC myopathy ده هيبقى for a short duration till a switch to either ablation or a more benign medication. انما بقى لو هو DCM ودي PVCs secondary to the DCM ده المريض الوحيد اللي احنا ممكن نبقى stuck فيه في خانة الاميودارون for a long time if the PVC cannot be cured with ablation.
I do agree with you that ejection fraction doesn't really represent the true function, because I think within the coming years there will be no more ejection fraction, because of course as we all know that if the patient have severe mitral regurg, for example, it is overestimated. So when you have an ejection fraction of 40, for example, and you have severe mitral regurg, probably it is 20 or so. So I think we need more more precise measurement for the ejection fraction. And I agree with you, but maybe the coming years will show us more
I also
data
think
about
the
that.
advances in CMR will add a lot into this, because myocardial fibrosis, clear and late gadolinium enhancement now took its role already in hypertrophic cardiomyopathy numerically. So if you have a late gadolinium enhancement that is more than 15%, that's a risk marker or a risk modifier. So as time goes by, I think this in particular will have its role in all cardiovascular diseases.
But I think that, you know, the CMR, maybe we need some cost-effective trials, because I think it's a rather very, you know, it's costly, and I think it will not be available everywhere. So I think maybe the volumes for the 3D echo may replace. Maybe we should look for other factors, I think, for measurement of function.
دكتور محمد حسن.
High PVC burden in structurally normal heart symptoms and low ejection fraction.
Exactly.
What about what's the value of suppressing these PVCs to avoid future LV dysfunction in patient is asymptomatic and normal LV ejection fraction? Is there a value to give a medical treatment to avoid this in the future?
If it's 2B indication, if it's more than 20%, there might be a value, but it's still 2B indication for catheter ablation, and it would be the same for medications, because the idea is the same. Do you need to suppress the PVCs or not? And the answer is, if it's more than 20%, you might think 2B indication, even if the patient is asymptomatic and normal ventricle.
Thank you very much, Dr. Ahmed. Excellent presentation, highly informative, and you summarized the guidelines in a very case-based, which is fantastic. I have two short comments. In these new guidelines, I have seen that there is upgrading for the programmed electrical stimulation in many recommendations. And we know that the sensitivity for the extra stimuli can be misleading for taking a decision based on programmed electrical stimulation. This is the first comment. The second one, the downgrading for ICD in non-ischemic cardiomyopathy, I think this was not based on Danish trial, because the last guidelines, it's published and we know the results of Danish. I think this is due to the favorable effect of the recent drugs, the guideline-directed medical therapy, in reversing remodeling, and the good impact and the good benefit in terms of reduction of volumes, improving ejection fraction, and reduction of ventricular arrhythmia and sudden death. And this can be seen in DABA-HF and in IMPRO-REDUCE trial, as well as in Paradigm. So these new drugs, which has a reverse remodeling effect and decrease the incidence of ventricular arrhythmia, this could be responsible for downgrading the indication for ICD in non-ischemic cardiomyopathy. So what's your...
يعني two excellent questions. I totally agree. أول حاجة أول observation يعني دي فعلا حاجة واضحة في الجايد لاينز، حتى كمان في النون اسكيميك، ودي حاجة مش العادي خالص. يعني our dogma is that programmed electrical stimulation is useless in patients with the non-ischemic cardiomyopathy. It could be helpful because of a high positive predictive value in ischemics, but in non-ischemics it's supposed not to have a high specificity. But this is what happened. They upgraded. But I'm pretty sure that this is not based on studies, and probably the evidence is level of evidence C, not A or B. I guess this is expert opinion is what affected the guidelines. بخصوص النيو medications، هو الحقيقة أنا يعني يظل هم الإيجكشن فراكشن هو المحك، بمعنى المرضى دول خدوا medical treatment والإيجكشن فراكشن فضل impaired تحت ال 35%، وخدوا كل الفور fantastic four and everything. Are they still at risk or not؟ انما طبعا لو هم خدوا الميديكال تريتمنت ده والايجكشن فراكشن عالي، by default they will come out of the indication. That's the point. I'm not sure that the medication effect was the issue. Besides, I'm not 100% of the data of the publication of the Danish, but I think it was very close to the 2015 guidelines. I'm not 100% sure though. وبرضو اللي انا بقى اتناقشت يمكن فيه مع حضرتك قبل كده، طيب هو الداون جريد من class 1 to class 2A, what does it really mean? The patient is still indicated for an ICD and he still gets an ICD as best practice, right? فبرضو اسمع رأي حضرتك.
I think individualized therapy should be considered based on the age. Genetic is very important, because if you have a family history of sudden death and genetic study is positive, CMR is very, very important to demonstrate the scar and fibrosis, which will increase the need for ICD. So, but if we have an elderly patient with a lot of comorbidities, so I will not go for ICD. But young age, genetic, CMR positive, all these are in favor to put an ICD earlier.
Exactly. Yeah. And this is the observation from practice. Younger patient controlled on medical treatment who are doing well are those patients who die suddenly rather than other patients. شكرا جزيلا.
شكرا دكتور احمد. Closing this session.